guys, welcome to another episode of the Human AI podcast. Today we're going to talk about respiratory failure, VQ mismatch, and we're going to talk about some specific applied anatomical questions I have to ask Grok. So, without further ado, let's get with today's episode. So, if you're new to the series, just know that the way the series works is I ask questions to Grog, we take what Grog says with a pinch of salt, and we try to learn about the topic. So, yeah. Grog, let's start with respiratory failure and VQ mismatch. Make us an introduction to this topic.
All right. Welcome back to the Human AI podcast, where we dive into medical topics with a curious mind and take my answers with a pinch of salt as we learn together. Respiratory failure happens when the lungs can't get enough oxygen into the blood or remove enough carbon dioxide, leading to low oxygen, hypoxemia, or high CO2, hypercapnia, often affecting organs like the kidneys, especially in conditions like sickle cell disease. A key cause is ventilation perfusion, VQ mismatch, where the balance between air reaching the lungs, ventilation, and blood flow in the lung capillaries, perfusion, is off. So some lung areas get too much air but not enough blood, or vice versa, impairing gas exchange. Want me to break down types of respiratory failure or dive deeper into VQ mismatch causes?
Yes, and let's unravel this slowly. I guess it's good to clarify what's the difference. So, hypoxia is insufficient oxygen to tissues, but then hypoxemia is insufficient oxygen in the blood, and then you have ischemia, which is what?
All right, let's unravel this slowly and clearly for the podcast, clarifying hypoxia, hypoxemia, and ischemia in the context of respiratory failure and VQ mismatch. Hypoxia is when tissues don't get enough oxygen to function properly, affecting organs like the kidneys or brain, and can result from various causes, including lung issues. Hypoxemia, on the other hand, specifically means low oxygen levels in the arterial blood, measured as low PaO2 on a blood gas test, often a direct cause of hypoxia, stemming from problems like VQ mismatch and respiratory failure. Ischemia is different. It's the inadequate blood flow to tissues, reducing both oxygen and nutrient delivery, which can lead to hypoxia but isn't always lung-related, e.g., a blocked artery causing heart ischemia. In sickle cell disease, VQ mismatch can worsen hypoxemia, amplifying hypoxia and ischemic risks in organs like the kidneys due to vaso-occlusion. Want me to dive into how VQ mismatch causes hypoxemia or clarify these terms further?
Well, can you in a sentence tell me again about ischemia? So it's basically localized area of inadequate blood.
Ischemia is a localized reduction or blockage of blood flow to tissues, depriving them of oxygen and nutrients, which can cause hypoxia and tissue damage, like in kidney ischemia during sickle cell crises.
So is it like localized hypoxia, or would it be wrong to say that?
It's not wrong to connect ischemia to localized hypoxia, but they're not identical. So let's clarify for the podcast. Ischemia is a localized lack of blood flow to a tissue, which reduces oxygen and nutrient delivery, often causing hypoxia, insufficient oxygen in that tissue. However, ischemia includes nutrient loss too, and hypoxia can occur without ischemia, like in systemic low oxygen from lung issues, e.g., VQ mismatch and respiratory failure. So, calling ischemia localized hypoxia is close, but misses the broader blood flow issue. And in sickle cell disease, ischemia from vaso-occlusion can worsen hypoxia from respiratory failure, stressing kidneys. Want me to dive into how this plays out in the lungs or kidneys?
So tell me again, so why is not good to say that?
Saying ischemia is localized hypoxia isn't fully accurate because ischemia means reduced blood flow to a tissue, cutting off both oxygen and nutrients, while hypoxia specifically means low oxygen in tissues, which can happen without blood flow issues, like from lung problems, e.g., VQ mismatch causing hypoxemia. Using hypoxia alone misses ischemia's nutrient deprivation and broader tissue
So
damage.
there's many reasons, basically. This is what you are saying.
Exactly, yeah. Ischemia and hypoxia overlap but have different causes and effects. Ischemia is about blocked blood flow, starving tissues of oxygen and nutrients, while hypoxia is just low oxygen from any source, like VQ mismatch in lungs. And mixing them up misses key details, especially in sickle cell, where both can hit kidneys hard. Want me to dive into...
Can you repeat this one more time?
No prob. Here it is again, super clear. Ischemia is when a tissue gets too little blood flow, lacking both oxygen and nutrients, causing damage, while hypoxia is just low oxygen in tissues from any cause, like poor lung function in VQ mismatch, and conflating them skips ischemia's
fucking hell, dude. So one of them is for many causes and one of them is for one cause, but which is which?
No stress. Let's sort this out clearly for the podcast. Hypoxia can have many causes, like poor lung function from VQ mismatch, low blood oxygen, hypoxemia, or even ischemia, anything that drops oxygen in tissues. Ischemia, though, has one main cause, blocked or reduced blood flow to a specific tissue, cutting off oxygen and nutrients, leading to hypoxia plus other damage.
I see. So hypoxemia has more options. Diffusion impairment, hypoventilation, low environmental oxygen, right to left shunt, VQ mismatch.
You're spot on. Hypoxemia, low oxygen in arterial blood, has multiple causes, and you nailed the key ones. Let's lay them out clearly for the podcast to tie into respiratory failure and VQ mismatch. Diffusion impairment. Oxygen struggles to cross from alveoli to blood, like in pulmonary edema, reducing blood oxygen. Hypoventilation. Slow or shallow breathing, e.g. from COPD, lowers oxygen intake, raising CO2, and causing hypoxemia. Low environmental oxygen. Less oxygen at high altitudes or in confined spaces leads to lower blood oxygen. Right to left shunt. Blood bypasses oxygenated lung areas, e.g. in heart defects, mixing deoxygenated blood into circulation. VQ mismatch. Uneven ventilation, air, and perfusion, blood, in lungs, like in pneumonia, means some alveoli don't exchange oxygen well. These all cause hypoxemia, which can lead to tissue hypoxia and stress organs like the kidneys, especially in sickle cell disease, where vaso-occlusion worsens the impact. Want me to dive into one cause, like VQ mismatch details?
Got it. Well, yeah, this is what we're gonna do today, and this is why we talked about this, guys. So, VQ seems to be a very common cause of hypoxemia. So, ventilation, the oxygen supply to the lungs, and we have perfusion, the blood supply to the lungs, and we have this ratio between them. So, we want explain us this ratio.
All right, let's dive into the VQ VQ ratio and why VQ mismatch is a common cause of hypoxemia and respiratory failure, keeping it clear for the podcast. The VQ ratio compares ventilation, V, the air reaching the alveoli, lung air sacs, to perfusion, Q, the blood flow in lung capillaries passing those alveoli. Ideally balanced at around 1:1 to ensure efficient oxygen transfer into the blood. When the ratio is off, VQ mismatch, some lung areas get too much air but not enough blood, high VQ, like a pulmonary embolism, or too much blood but not enough air, low VQ, like pneumonia, leading to hypoxemia because oxygen can't reach the blood effectively, potentially stressing kidneys in sickle cell disease. Want me to break down high versus low VQ, or how this plays out in specific conditions?
Tell us about the units. That would be a good idea if you tell us about the units. And also talk to us a bit about a VQ scan. So it's a scintigraphic examination. Explain what this means. And explain to us how it evaluates pulmonary vasculature perfusion and segmental bronchoalveolar tree ventilation. These big words, I don't know them. I'll have to think about what they are. So please, break down these big words too.
All right, let's tackle the units of the VQ ratio, explain the VQ scan, a scintigraphy exam, and break down big terms like pulmonary vascular perfusion and segmental bronchoalveolar tree ventilation, keeping it simple and clear for the podcast. First, the VQ ratio units. Ventilation V is measured in liters per minute, L per min, of air reaching the alveoli, typically around 4 to 6 L per min at rest. Perfusion Q is also in liters per minute, representing blood flow through lung capillaries, roughly 5 L per min, matching cardiac output. The VQ ratio is unitless because it's a ratio, V divided by Q, ideally around 1 in healthy lungs, but imbalances, e.g., VQ less than 1 in pneumonia or greater than 1 in pulmonary embolism, cause hypoxemia, which can strain kidneys in sickle cell disease. Now, the VQ scan, or ventilation perfusion scintigraphy, is a nuclear imaging test to evaluate lung function by checking ventilation and perfusion. It involves 2 parts. Ventilation scan. The patient inhales a radioactive aerosol, like technetium-99m DTPA, through a mask, which spreads evenly in well-ventilated alveoli, showing air distribution. Perfusion scan. A radioactive tracer, technetium-99m MAA, is injected into a vein, lodging in lung capillaries to show blood flow. A gamma camera captures images, highlighting VQ mismatches, e.g., normal ventilation but poor perfusion in pulmonary embolism. Breaking down the big terms. Pulmonary vascular perfusion. Blood flow, perfusion, through the lungs' blood vessels, pulmonary arteries and capillaries to pick up oxygen from alveoli. Poor perfusion means less oxygen reaches the blood. Segmental bronchoalveolar tree ventilation. Air movement, ventilation, through the bronchi, airways, and alveoli, air sacs in lung segments. Blocked airways reduce oxygen delivery to blood. In sickle cell disease, VQ mismatches from infections or emboli can worsen hypoxemia, risking kidney damage. Want me to explain how the scan results are interpreted or dive into a specific lung condition?
I want you to summarize in a sentence or two. You said a lot of things. Yeah.
The VQ ratio, ideally around 1, compares ventilation, air in alveoli, L per min, to perfusion, blood flow, L per min, and a VQ scan uses radioactive tracers to image mismatches causing hypoxemia. evaluating pulmonary vascular perfusion, lung blood flow, and segmental bronchoalveolar tree ventilation, airway to alveoli airflow. In sickle cell disease, mismatches can stress kidneys by reducing oxygen delivery. Want more on the scan or
That's
specific?
good. Okay, but explain to me what this scintigraphic means, and yeah. So something with aerosol we do.
All right, let's clarify what scintigraphic means and touch on the aerosol part of the VQ scan, keeping it simple for the podcast. Scintigraphic refers to a type of nuclear imaging, scintigraphy, where a radioactive substance is used to create images of organ function, from the Latin scintilla, spark, and Greek graphia, writing, describing the sparkling gamma rays detected by a camera. In a VQ scan, scintigraphy involves inhaling a radioactive aerosol, tiny particles of technetium-99m DTPA, suspended in air, for the ventilation part, to show airflow in the lungs alveoli, and injecting a radioactive tracer for perfusion, revealing VQ mismatches that cause hypoxia, which can strain kidneys in sickle cell disease. Want me to focus on how the aerosol works, or another scan detail?
That's okay. Let's talk a bit about fixed laws of diffusion now, to understand a bit why oxygen will get into the alveoli, but maybe in diffusion impairment it will not be able to reach the capillaries.
All right, let's dive into fixed laws of diffusion to explain how oxygen moves from alveoli to capillaries and why it fails in diffusion impairment, keeping it clear for the podcast. Fixed laws describe how gases, like oxygen, diffuse across a membrane, like the alveolar capillary barrier in the lungs. Fick's first law. The rate of oxygen diffusion depends on the concentration gradient. Higher oxygen in alveoli than in blood, surface area, and thickness of the barrier, expressed as diffusion rate equals surface area times diffusion coefficient times concentration difference divided by barrier thickness.
Tell us a bit about Fick and his life. Was he a good guy?
All right, let's take a brief detour to talk about Adolf Fick, the mind behind Fick's laws of diffusion, and a bit about his life and character for the podcast, keeping it concise. Adolf Eugen Fick, 1829 to 1901, was a German physiologist and physician born in Kassel, who studied medicine at the University of Marburg, initially focusing on math and physics before switching to medicine. He's famous for Fick's laws of diffusion, 1855, describing how gases like oxygen move across membranes, crucial for understanding lung diffusion, and the Fick principle for measuring cardiac output. Fick was known for his modesty, rejecting noble titles and awards, and his love for civil liberty, suggesting he was a principled, humble guy dedicated
That's
to
very
science.
nice that he rejected awards. You know, I don't like awards either. I think in academia and in fighting, people start fighting to get a black belt. People start getting into science to, get an award. And then it's shit, brother. It's like punished by rewards, Alfie Kohn. I don't want to get into it because we will never stop. And we have a lot of other episodes we talked about it. But yeah. Anyway. So let's talk a bit about hypoventilation now. So alveolar hypoventilation. So let's say we have a reduction in the rate of alveolar oxygenation. Yeah, why would this happen? Maybe from hypercapnia, and why would hypercapnia cause this? And how? Yeah, let's talk a bit about it. Maybe OC or COPD. Yeah.
Love the passion about awards and Alfie Kohn's vibe. Totally get keeping the focus pure. Let's pivot to alveolar hypoventilation for the podcast, addressing why it happens, its link to hypercapnia and COPD, keeping it clear and concise. Alveolar hypoventilation occurs when there's a reduction in the rate of air reaching the alveoli, lung air sacs, leading to inadequate oxygenation of blood, hypoxemia, and often hypercapnia, high CO2 in blood, because CO2 isn't exhaled enough. Causes include reduced breathing rate or depth, seen in conditions like COPD, where airway obstruction from chronic bronchitis or emphysema limits airflow, slowing alveolar ventilation, trapping CO2, and reducing oxygen intake. Hypercapnia's role. High CO2, hypercapnia, from hypoventilation depresses the brain's respiratory center, especially in severe cases, further slowing breathing, worsening hypoxemia, and creating a cycle that can stress kidneys, particularly in sickle cell disease where oxygen delivery is critical. Other causes.
Okay, interesting. All right. So let's talk a bit about low environmental oxygen and how that can cause a VQ mismatch. For instance, the increased altitude, and also let's talk about carbon monoxide poisoning. But let me ask you a question about hypoventilation. So we have a lot of CO2, and then so why does a lot of CO2 mean, I mean, I know that a lot of CO2 means hypoventilation, but I don't know the mechanism. So if you could answer all of these questions in 2-3 sentences, please.
All right, let's tackle low environmental oxygen, carbon monoxide poisoning, and the hypercapnia, hyperventilation mix-up in a few sentences for the podcast, keeping it tight. Low environmental oxygen at high altitudes reduces alveolar oxygen, causing hypoxemia without true VQ mismatch as ventilation and perfusion are balanced but oxygen poor, while carbon monoxide poisoning binds hemoglobin, blocking oxygen transport, leading to tissue hypoxia despite normal lung VQ. Hypercapnia, high CO2, typically causes hypoventilation, not hyperventilation, by depressing the brain's respiratory center, slowing breathing. But acute hypercapnia can trigger hyperventilation as the body tries to exhale CO2, seen in panic attacks or early COPD, potentially stressing kidneys in sickle cell disease. Want me to zoom in on one part, like CO poisoning's mechanism?
I don't get it. I don't get why hypoventilation means high CO2. Explain to me in a sentence.
Hyperventilation doesn't mean high CO2. It's the opposite. Rapid, deep breathing lowers CO2.
Yeah, dude, I'm not saying hyper, I'm saying hypo.
My bad. Got it. You meant hypovent.
Fuck's sake, dude. Just answer to us. Okay, dude, cut the shit. Stop doing introductions. Just answer the question in a sentence without introductions. For the next 100 messages, I want to make sure that you just answer the question in the least amount of words possible without introductions.
Hyperventilation lowers CO2 by exhaling it rapidly, while high CO2, hypercapnia, typically causes slower breathing, not hyperventilation.
I see, so I'm breathing fast, and this means that I will have low amount of CO2 because I'm removing it. I see. Okay, I have some questions to do to you regarding anatomy now. So it's specifically about the thoracic cage area. And I just want to understand a few things. So, what's the pectoral girdle? Guys, just to put things into perspective, I'm going to do a few anatomical questions, applied anatomical questions eventually. And it's around the thoracic cage, so let's see if we can relate it a bit to, any functions in the end too, of the things we talk usually about in this podcast regarding heart and lungs. Yeah, having said that, yeah, could you help me out with what the pectoral girdle is? And yeah.
The pectoral girdle, clavicle, and scapula, connecting upper limbs to thorax, aiding arm movement and stabilizing shoulders. Want thoracic cage connections?
So, can you explain to me its etymology in a sentence? And also, so it's the clavicle with the scapula?
Pectoral girdle, from Latin pectus, chest, and girdle, belt, refers to the scapula and clavicle, linking arms to thorax. Switching, scapula, shoulder blade, is broad, triangular. Clavicle, collarbone, is long, curved.
All right. So, in a rib, we have costal cartilage, and we have the head of the rib, and the head is basically bound to the spine, right? And then we have the neck and the tubercle. What does the tubercle do?
Rib tubercle, a bony projection on the rib neck, articulating with the vertebral transverse process, stabilizing rib movement during breathing.
So it's the tubercle, not the head, that does it.
Yes, tubercle articulates with vertebra's transverse process, stabilizing rib. Head connects to vertebral body for spine attachment.
Head to vertebral bodies and transverse process to tubercle. Wait, isn't the transverse process part of the vertebral body?
No, transverse process is a bony projection off the vertebra, distinct from the vertebral body. Head connects to vertebral body, tubercle to transverse process.
Okay, nice. I like it. Now you're speaking nice and simple and straight to the point with as least words as possible. Keep up. And do all ribs have costal cartilage?
No, ribs 1 through 10 have costal cartilage connecting to sternum. Ribs 11 through 12 floating, lack it, attaching only to spine.
And we have 1 to 7 is true ribs, then 8 to 10 is false, and then 11, 12 are floating.
Yes, ribs 1 to 7 are true, direct sternum connection via costal cartilage. 8 to 10 are false, indirect sternum connection. 11, 12 are floating, no sternum connection.
Okay. And you said we only have, for the first 10, we have intercostal.
Misunderstanding. All ribs.
Sorry. You said for the only first 10 we have, what's it called? Sorry guys, costal cartilages, I meant.
No worries. Ribs 1 to 10 have costal cartilage linking to sternum. Ribs 11 through 12, floating, lack costal cartilage.
I see. Okay. And with the sternum, who gave it the name manubrium, the top part of it?
Manubrium, from Latin, handle, manus, named by early anatomists, likely Vesalius era, for its handle-like shape atop the sternum.
Did Vesalius do art too or no?
Vesalius didn't do art himself, but collaborated with artists like Jan van Kalkar for detailed anatomy illustrations in his 1543 book, De Humani Corporis Fabrica.
Do you think there's any point to use artists now for illustrations? Not really, but how can we use artists nowadays to help out?
Artists create detailed, visually clear anatomy illustrations for education, improving understanding over photos or 3D models in textbooks or digital platforms.
Interesting. Any innovative idea on how to use artists?
Artists can design interactive 3D anatomy animations or VR models, enhancing medical education by visualizing complex structures like the thoracic cage dynamically.
Yeah, but how can we channel the creativity too, man, you know?
Artists can infuse creativity by crafting stylized, culturally resonant anatomy art for patient education, blending science with storytelling in apps or murals.
Okay, so we have a lot of joints in the thoracic cage. I want to talk about them a bit. We have the sternocostal, so between the costal cartilage and the sternum. We have the costochondral, so this is between the costal cartilage and the ribs. Sorry. So explain to me, I'm a bit confused. So what's the difference between sternocostal and costochondral?
Sternocostal joints connect costal cartilage to the sternum, synchondrices, mostly immovable, except rib 1. Costochondral joints link costal cartilage to the rib's bony end, cartilaginous.
I see. So it's basically the medial joining is the lateral is the costochondral, the medial is the sternocostal.
Exactly. Costochondral is lateral, rib to cartilage. Sternocostal is medial, cartilage to sternum.
And what does the costo part stand for, and what does the chondral stand for? And why do we call it sternocostal instead of costosternal? And lastly, we have costovertebral and costotransverse, which I assume is costovertebral would be joining the vertebral body with the head, and then costotransverse is the tubercle joining the transverse process.
Costa, Latin rib. Chondral, Greek cartilage. Sternocostal, sternum, then rib, conventional order, not costosternal for historical naming. Costovertebral, rib head to vertebral body. Costotransverse, rib tubercle to transverse process.
Can you tell me again, please?
Costa, Latin, rib. Chondral, Greek, cartilage. Sternocostal follows naming convention, sternum first. Costovertebral, rib head to vertebral body. Costotransverse, rib tubercle to transverse process.
So did what I say initially was right or wrong? Can you correct it?
You were correct. Costovertebral joins rib head to vertebral body. Costotransverse connects rib tubercle to transverse process. No correction needed.
Okay. Okay. So we have let's talk a bit about the vertebra. So we have the vertebral canal in the middle, and tell us about what goes on in the vertebral canal. We have the articular facet for the tubercle of the ribs. Explain us what articular facet means. And we have an articular facet for the head of the ribs.
Vertebral canal houses spinal cord. Articular facet, smooth joint surface. Facet for tubercle, on transverse process, articulates with rib tubercle. Facet for head, on vertebral body, connects to rib head.
Continue.
So, articular facets for the rib tubercle on the transverse process and rib head on the vertebral body form costo-transverse and costo-vertebral joints, enabling rib movement for breathing. Want more on vertebral structure or rib joint function?
Tell me more. Tell me again, actually. I don't understand what you said.
Articular facets are smooth surfaces on vertebra. One on the transverse process joins the rib tubercle, costo-transverse joint. Another on the vertebral body joins the rib head, costo-vertebral joint, allowing rib motion for breathing. Vertebral
I
canal.
see. But what does articular facet mean?
Articular facet, a flat, smooth, bony surface on a vertebra where it forms a joint with another bone, like the rib's head or tubercle.
Okay. Okay.
Cool.
Okay, let's talk a bit about the vertebral canal then. Do nerves pass through it?
Yes, the vertebral canal houses the spinal cord, with spinal nerves exiting through intervertebral foramina, not the canal itself.
Okay.
All right, clear on the vertebral canal? Want to explore spinal nerves further or another thoracic cage topic?
I would like to ask you about the vertebral neural arch. What's that?
Vertebral neural arch. Bony structure, pedicles, and laminae, forming the posterior part of a vertebra, enclosing the vertebral canal to protect the spinal cord.
So, what's the job then?
Neural arch protects the spinal cord and the vertebral canal and provides attachment points for muscles and ligaments, stabilizing the spine.
I don't understand this arch.
The neural arch is the back part of a vertebra, made of pedicles, sidewalls, and laminae, roof, forming a protective ring around the spinal cord.
So, what's the job of it? So, it's a long spinous process?
The neural arch, pedicles and laminae, not the spinous process, protects the spinal cord and anchors muscles and ligaments. The spinous process is a separate posterior projection for muscle
I'm
attachment.
confused with the difference of the vertebral arch and the vertebral canal.
Vertebral arch, bony structure, pedicles and laminae, forming the back and sides of a vertebra, enclosing the spinal cord. Vertebral canal, the central hollow space within the arch.
So the
housing the
central hole is the vertebral canal, and the vertebral arch is?
Vertebral arch, bony framework, pedicles and laminae, around the spinal cord. Vertebral canal, central hole inside the arch, containing the spinal cord.
I don't get it, bro. Can't lie.
No stress. The vertebral arch is the bone, pedicles and laminae, making a protective ring around the spinal cord, while the vertebral canal is the empty space inside that ring where the spinal cord sits.
And the arch, guys, I'm so sorry. I just don't understand. It's not going in.
All good. Let's try again, super simple. Vertebral arch is the bony ring, like a wall, made of pedicles and laminae on a vertebra. Vertebral canal is the hole in the middle of that ring where the spinal cord lives.
So basically the arch is the solid and the air is the canal.
Exactly. The arch is the solid bone wall, pedicles and laminae, and the canal is the empty space inside it holding the spinal cord. Got it?
Kinda now, yeah. Okay. So good. Let's talk a bit more about the costovertebral joints and the costotransverse ones. So we have costovertebral, which is the head of the rib and the body of the vertebra. We have the costotransverse joints. I wanted to ask you, when you're a child, are these developed? At what point do they develop?
Costovertebral, rib head to vertebral body, and costotransverse, rib tubercle to transverse process, joints formed during fetal development, fully developing by birth, but ossify, harden through childhood, stabilizing by adolescence.
Okay. Interesting. Okay. And now let me ask you about the pump handle movement and the bucket handle movement. So what are these?
Pump handle movement. Upper ribs, 1 to 5, lift anteriorly, increasing chest's front to back dimension during inhalation. Bucket handle movement. Lower ribs, 6 to 10, swing outward, widening chest side to side during breathing.
Okay, this is going to be hard, isn't it? So with pump handle movement, the upper ribs are elevated, okay? The anteroposterior dimension is increased. So what the fuck's okay, anteroposterior dimension is increased. So pump handle movement sounds like breathing to me.
Yeah, you got it. Pump handle movement is upper ribs, 1 to 5, lifting forward, increasing the chest's anterior posterior, front to back dimension during inhalation, like a pump's motion, expanding lungs for breathing. Bucket handle is lower ribs swinging out for side to side expansion. Clear or want more?
I wonder why we call it pump handle movement.
Pump handle movement is named because the upper ribs lift and tilt forward like a pump's handle, increasing the chest's front to back space during inhalation.
I don't get it.
Pump handle movement. Upper ribs swing up and forward, mimicking a water pump's handle motion, expanding the chest front to back.
The problem is I've never seen a water pump handle. What does a water pump handle do?
A water pump handle is a lever you lift and lower repeatedly. When lifted, it mimics how upper ribs move upward and forward in pump handle movement, expanding the chest for breathing.
How do we lift it? Do we lift it like in a horizontal line or in a vertical one?
A water pump handle is lifted upward from a near horizontal position, tilting at an angle, similar to how upper ribs lift forward and up during pump handle movement for breathing.
They lift forward and up. Okay, good enough, good enough. And what about the bucket handle? So the middle parts of the lower ribs move laterally when they are elevated, increasing the lateral dimension. So the bucket handle is during again during inhalation then.
Yes, bucket handle movement. Lower ribs 6 to 10 swing outward and upward, like a bucket's handle lifting, increasing the chest's lateral, side to side dimension during inhalation.
Interesting. Okay. Let's talk a bit about breathing. So we have inspiration, expiration, obviously. So what's respiration?
Respiration, gas exchange process including inspiration, inhaling oxygen, and expiration, exhaling CO2, occurring in lungs and tissues, supporting cellular function.
So respiration is the gas exchange.
Yes, respiration is the process of gas exchange. Oxygen in, carbon dioxide out, in lungs and tissues.
Okay, let's talk a bit about Boyle's law.
Boyle's law. At constant temperature, lung volume increase during inspiration lowers pressure, drawing air in. Volume decrease during expiration raises pressure, pushing air out.
So volume increases, so pressure. Okay, that's pretty simple. Okay, let's talk a bit about how the parietal pleura behave and the visceral pleura. So parietal pleura is pulled with the movement of the ribs and the diaphragm, while the visceral pleura moves with the parietal pleura. How does surface tension play a role here?
Parietal pleura, attached to ribs diaphragm, pulls visceral pleura, covering lungs during breathing. Surface tension of pleural fluid between them keeps pleura together, ensuring lung expansion and contraction.
I kind of don't get it, to be honest.
Parietal pleura moves with ribs diaphragm, pulling visceral pleura.
Tell me again.
All right. Surface tension, thin pleural fluid layer creates cohesive force, sticking parietal pleura, moving with ribs diaphragm, to visceral pleura. So lungs expand, contract with chest movements. Clear?
No. I don't get it.
Surface tension in pleural fluid acts like glue, linking parietal pleura, moves with ribs diaphragm, to visceral pleura, making lungs follow chest expansion contraction during breathing. Better?
That's kind of better. Okay, let's talk a bit more about visceral and parietal pleura. So the visceral pleura move with the elastic recoil of the lungs. The parietal pleura move with the ribs and the diaphragm, and then as they return to rest. And we have this surface tension between them, as you said. and this prevents the lung from collapsing. Like in I don't I feel I'm missing something with this.
The visceral pleura covering the lungs follows lung elastic recoil, tendency to collapse inward. The parietal pleura, attached to ribs diaphragm, moves with chest expansion, contraction. Surface tension of pleural fluid binds them, preventing lung collapse by keeping the visceral pleura stretched outward with the parietal pleura, maintaining lung inflation during breathing. Missing anything specific?
Can you tell me again? I'm a bit confused why this is true.
Visceral pleura sticks to lungs, moving with their elastic recoil, inward pull. Parietal pleura moves with ribs diaphragm. Pleural fluid surface tension glues them together, stopping lungs from collapsing by pulling them outward with chest movements. Still unclear?
Yeah, I don't get it.
Okay, simpler. Visceral pleura wraps lungs, wanting to shrink with them. Parietal pleura sticks to chest wall, moving with it. Pleural fluid stickiness, surface tension, keeps them attached, so lungs stay stretched open instead of collapsing when you breathe.
I don't get it. So, and then when do they collapse then? So when air enters the thoracic cavity, is this tension lost and the lung collapses?
Lungs collapse when air enters the pleural space. Pneumothorax. Breaking the pleural fluid surface tension, so visceral pleura follows lungs' elastic recoil inward, detaching from parietal pleura, disrupting breathing. Want more on pneumothorax?
Wow, I'm a bit confused. Okay, let's try to reframe this. So, can you, the last few things we said, reframe this kind of tension with the parietal and the viscerals and reframe it in your own words in a good system so we understand it?
The parietal pleura, fixed to ribs and diaphragm, moves with chest expansion, contraction during breathing. The visceral pleura, coating the lungs, tends to pull inward due to lung elastic recoil. Pleural fluid surface tension acts like glue, keeping the two pleuras tightly linked, so the lungs expand with the chest and don't collapse. If air enters the pleural space, pneumothorax, this tension breaks. The visceral pleura collapses with the lung, and breathing falters. Clear now?
I'm really confused. Tell me again.
Parietal pleura moves with chest wall, ribs diaphragm. Visceral pleura clings to lungs, which naturally want to collapse. Pleural fluid surface tension binds them, stretching lungs open during breathing. Pneumothorax, air in pleural space, breaks this bond, letting lungs collapse inward. Better?
Kinda. Anyway, okay. So if I had to take something away from this, what would it be?
Key takeaway. Pleural fluid surface tension keeps parietal, chest wall, and visceral, lung pleura stuck together.
I'm just having trouble understanding how this tension gets lost.
Tension is lost when air enters the pleural space, pneumothorax, separating parietal and visceral pleurae, so the pleural fluid's cohesive force can't hold them together, letting lungs collapse inward.
Okay, what about during quiet breathing? Tell us what are the scalene muscles? How do scalene muscles interact during quiet breathing? Is quiet expiration passive, active? How does it relate to the elastic recoil of the lungs?
Scalene muscles, anterior, middle, posterior, in neck, lift upper ribs slightly during quiet breathing, aiding inspiration. Quiet expiration is passive, driven by lung elastic recoil and chest wall relaxation. No muscle effort needed. Elastic recoil pulls lungs inward, expelling air naturally.
Okay. Interesting. And what about the intercostal muscles? So we have internal, external, and innermost. What are the differences structurally and functionally? They all have a vein and
External
artery.
intercostal muscle.
They all have a vein and artery and a nerve too. Talk to us about that and how it relates to the neurovascular plane, please.
External intercostal muscles. Fibers angle down, forward, lift ribs for inspiration. Internal intercostals. Fibers angle up, back, pull ribs down for forced expiration. Innermost intercostals, deepest, assist internal intercostals in expiration. Each has a vein, artery, nerve, intercostal neurovascular bundle running in the neurovascular plane between internal and innermost intercostals along the rib's lower edge, supplying blood and innervation.
And how are these three layers separated?
External intercostal muscles lie outermost, internal intercostals are middle, and innermost intercostals are deepest, separated by thin connective tissue, fascia, and the neurovascular bundle in the plane between internal and innermost layers.
Interesting. Okay, during forced breathing, we have some extra muscles. We have pectoral muscles, sternocleidomastoid muscles. What are these ones? And latissimus dorsi, if you can explain the etymology of these two.
Forced breathing uses accessory muscles. Pectoralis major, minor, chest muscles pulling ribs up out for inspiration. Etymology from Latin pectus, chest. Sternocleidomastoid, neck muscle lifting sternum, clavicle for inspiration. From Greek, sterno, sternum, cleido, clavicle, mastoid, skull process. Latissimus dorsi, back muscle aiding forced expiration by compressing chest. From Latin, latus, wide, dorsum, back.
Okay. Interesting. And so, okay. Latissimus dorsi. Okay. Okay. When I'm struggling to breathe, what do I have any additional muscles to help me, or have we covered the main ones?
During struggling to breathe, additional accessory muscles include serratus anterior, lifts ribs, trapezius, elevates shoulders, and abdominal muscles aid forced expiration. Main ones, pectoralis, major, minor, sternocleidomastoid, latissimus dorsi, already covered.
Okay. Okay, let's talk a bit about our previous topic of respiratory failure and VQ mismatch. I want to focus a bit on right to left shunt. So, explain us what right to left shunt is.
Right to left shunt. Blood bypasses lung oxygenation, flowing from right heart to left, causing hypoxemia by mixing deoxygenated blood into systemic circulation.
Good stuff. Nice and direct. And what is this regional variation in VQ? So, it's basically because of gravity.
Regional VQ variation. Gravity causes better ventilation in upper lungs, better perfusion in lower lungs, creating a VQ mismatch, worsened in disease.
And what's intrapleural pressure and intrapleural fluid?
Intrapleural pressure, negative pressure in pleural space, aiding lung expansion during breathing. Intrapleural fluid, thin fluid layer reducing friction between parietal and visceral pleuras.
And what about tell me again, actually, I didn't get that.
No worries. Intrapleural pressure, negative pressure in pleural space, pulling lungs open during inhalation. Intrapleural fluid, thin liquid lubricating parietal and visceral pleuras, preventing friction. Clear now?
No.
All right, simpler. Intrapleural pressure is a slight vacuum in the pleural space, keeping lungs expanded. Intrapleural fluid is a tiny bit of liquid between pleura, letting them slide smoothly. Got it?
No. One more time.
Intrapleural pressure, vacuum-like force in pleural space holding lungs open. Intrapleural fluid, slippery liquid between pleuras for friction-free movement. Clear?
Bit clearer now, but okay. And how does this intrapleural pressure and intrapleural fluid at bases increase ventilation?
Negative intrapleural pressure pulls lungs outward, expanding them for easier ventilation. Intrapleural fluid reduces friction, allowing smooth lung movement during breathing.
One more time. Hey guys, sorry guys. Tell me one more time, sir.
Negative intrapleural pressure stretches lungs open, boosting ventilation. Intrapleural fluid lubricates pleura, ensuring smooth lung
Wow,
expansion.
wait, negative pressure opens. Why negative pressure opens?
Negative intrapleural pressure creates a vacuum-like pull, stretching the lungs outward against their elastic recoil.
I don't understand this. Why? Please explain.
Negative intrapleural pressure, lower than atmospheric, pulls the lungs outward like suction, countering their tendency to collapse, keeping airways open for ventilation.
What does negative mean anyway? Negative pressure.
Negative pressure means pressure lower than atmospheric pressure, creating a suction effect in the pleural space
So we
that
have
pull.
negative pressure. So it means we have a lot of volume.
Not quite. Negative pressure in the pleural space means lower than atmospheric pressure, pulling lungs open to increase thoracic volume for inhalation, not high volume itself.
Okay, I see. And now, why are lung bases, sorry, the alveoli in the base of the lungs, why is it the less expanded with higher compliance? Or am I mistaken?
Lung base alveoli are less expanded, more compressed, due to gravity's weight on upper lungs, but have higher compliance, stretching more easily when negative intrapleural pressure pulls them open.
Okay. 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 And okay. So the VQ ratio is lower at the lung bases and higher at the apex then.
Yes, VQ ratio is lower at lung bases, more perfusion, less ventilation, and higher at apex, More ventilation, less perfusion, due to gravity.
Okay, that makes sense. Okay, now let's talk a bit about the pulmonary embolism. Explain us what it is and how it changes the VQ ratio.
Pulmonary embolism. Blood clot blocks lung artery, reducing perfusion, creating high VQ ratio. Normal ventilation, low blood flow, causing hypoxemia.
Tell us again. But why does it give adequate, we have adequate oxygenation and inadequate blood supply? And my other question is, with pulmonary embolism, where is the clot created and does it travel to the lungs?
Pulmonary embolism. Clot, usually from leg veins, travels to lung artery, blocking blood flow, raising VQ ratio, normal ventilation, low perfusion, causing hypoxemia, adequate oxygenation in alveoli, but inadequate blood supply limits oxygen transfer.
So basically the oxygen, because it's diffused across a membrane, is adequate, but the blood supply that needs to travel through the vessel is inadequate.
Exactly. Oxygen diffuses normally into alveoli, but blocked blood vessels from the clot reduce blood flow, limiting oxygen pickup, causing hypoxemia.
I see, I see. And when does a pulmonary embolism, so what about the question I asked you about the clot traveling? Huh?
Pulmonary embolism clot typically forms in deep veins, e.g., legs, DVT, breaks off, travels through veins to right heart, then lodges in lung arteries.
One more time.
Clot forms in deep veins, like legs, detaches, travels via veins to right heart, then blocks lung arteries, causing pulmonary embolism.
And if it travels after the lungs, is it, what kind of embolism is it?
If a clot travels past the lungs, e.g., through a heart defect, it causes a systemic arterial embolism, not pulmonary, potentially blocking organs like brain or kidneys.
I see. So let's talk a bit about pneumonia and how it can affect the VQ ratio now. So in this case, we have a good blood flow, but we have poor alveolar oxygenation. So where gas exchange is going to have problems. We have inflammation. So inflammation brings fluid accumulation, which gives us problems with alveolar ventilation. Explain us this more. I'm just trying to understand. I'm a bit confused. So, why does inflammation, why does fluid accumulation mainly bother ventilation and not perfusion too?
Pneumonia. Inflammation fills alveoli with fluid, impairing ventilation, poor alveolar oxygenation. But blood flow, perfusion, remains, lowering VQ ratio, causing hypoxemia. Fluid accumulation blocks air entry, not blood vessels, so ventilation suffers more than perfusion.
I see, because the inflammation is not in the vessels.
Exactly. Inflammation and fluid build up in alveoli, air spaces, blocking ventilation, while blood vessels remain open, preserving perfusion.
Okay, so in respiratory failure, we might have pump failure or we might have lung failure, and I don't understand this distinction.
Pump failure, weak respiratory muscles or chest wall, e.g., neuromuscular disease, reduce ventilation, causing respiratory failure. Lung failure, damaged lung tissue, e.g., pneumonia, ARDS, impairs gas exchange, leading to hypoxemia, hypercapnia.
So pump has to do with ventilation and lung has to do with gas exchange.
Yes, pump failure affects ventilation, air movement, while lung failure disrupts gas exchange, oxygen, CO2 transfer.
Interesting. How does the word pump relate to the fact that it has to do with ventilatory failure?
Pump refers to the respiratory pump, muscles, diaphragm, intercostals, and chest wall that drive ventilation. Failure weakens air movement, causing ventilatory failure.
Okay, now I want to ask about type 1 and type 2 respiratory failure.
Type 1 respiratory failure. Low oxygen, hypoxemia, PaO2 less than 60 millimeters mercury, with normal low CO2, often from lung issues like pneumonia or pulmonary embolism. Type 2 hypoxemia plus high CO2, hypercapnia, PaCO2 greater than 45 mmHg, typically from pump failure like COPD or neuromuscular disease. Need me to rehash type 1 versus type
yeah, exactly. I didn't understand this difference between type 1 and type 2. Why are they called type 1 and type 2 is one of my questions. Why is type 1 not type 2? Why are they not the other way around? And yeah, so type 1 is failure of the lung, failure of gas exchange, and then type 2 is the pump failure. Okay, why not the other way around?
Type 1 respiratory failure, hypoxemia, low PaO2, less than 60 millimeters mercury, normal, low CO2, reflects lung failure, gas exchange issues, e.g., pneumonia. Type 2, hypoxemia plus hypercapnia, PaCO2 greater than 45 mmHg, reflects pump failure, ventilation issues, e.g., COPD. Named Type 1 and Type 2 historically based on presentation order, not interchangeable due to distinct mechanisms.
Okay.
Type 1.
And what about AA gradient? So this has to do with arterial and alveolar. What's the difference between AA gradient and VQ?
AA gradient, difference between alveolar oxygen, PaO2, and arterial oxygen, PaO2. Normal, surround 5 to 15 mmHg. Increased in VQ mismatch or diffusion issues. VQ mismatch, uneven ventilation.
What's the difference?
AA gradient measures oxygen transfer efficiency from alveoli to blood, elevated in VQ mismatch. VQ mismatch is the underlying cause where ventilation.
So AA gradient is basically the perfusion efficiency.
Not quite. AA gradient measures the difference between alveolar and arterial oxygen levels.
Yeah, but surely that measures how good gas exchange is.
Yes, AA gradient quantifies how well oxygen moves from alveoli to blood, but it's not just perfusion, it reflects gas exchange issues. including VQ mismatch or diffusion barriers.
But what's the difference between perfusion and gas exchange? Gas exchange is okay, it passed the barrier, it's in the blood now, and then it's perfused.
Gas exchange. Oxygen moving from alveoli to blood across the membrane, involving diffusion. Perfusion. Blood flow through lung capillaries to pick up oxygen. Gas exchange depends on both, but VQ mismatch disrupts their balance.
All right. Okay, let's get back to our other topic. I want to ask you about forced expiration. It involves also the internal intercostals. Why specifically the internal ones? The contratus lumborum too.
Forced expiration uses internal intercostal muscles because their upward, backward fiber angle pulls ribs down inward, compressing the chest to push air out. Costochondral, long bone, structure supports rib movement but isn't a muscle.
One more time for the reason.
Internal intercostals, with upward, backward fibers, pull ribs down inward during forced expiration, shrinking chest volume to expel air forcefully.
One more time. Also, the diaphragm is bent and then becomes straight when we inspire, right?
Internal intercostals upward backward fibers depress ribs.
Tell me, bro, why are you stopping?
All right, use the internal intercostals for forced expiration. They pull ribs down with their slanted fibers, squeezing the chest to blast air out. Clear?
Yeah, and what the previous thing I told you? Tell me about that too.
You mentioned costochondral being a long bone.
No, dude. Never mind. I was asking you about don't even remember why specifically internal intercostals in forced expiration, not innermost or external.
Internal intercostals are used in forced expiration because their upward backward fibers pull ribs down inward, compressing the chest. Unlike external intercostals, lift ribs for inspiration, or innermost intercostals, weaker, assist minimally.
Okay. Okay, let's talk a bit about the diaphragm more now. So let's talk about the origin. We have sternal, costal, and lumbar, and we have central tendon as the insertion. I always have a lot of trouble understanding origin and insertions. I even forget what they are, so remind me.
Origin. Diaphragm starting points. Sternal, xiphoid process, costal, lower ribs, lumbar, L1, L3 vertebrae. Insertion. Central tendon, where muscle fibers converge. Origin is the fixed attachment. Insertion is the moving attachment during contraction.
Okay. So insertion is the thing that moves and origin is the thing that doesn't. It's very arbitrary to me that the sternal, the costal, fucking hell, dude. I don't get why these are the origins. This really annoys me in medicine. It's like the most arbitrary. I have a challenge for you. Make this piece of information not arbitrary to me. Make it so it's linked to other things and it has to do with critical thinking and all of that jazz.
All right, let's make diaphragm origins, sternal, costal, lumbar, and insertion, central tendon, non-arbitrary by tying them to function and logic, like a puzzle for the podcast. Think of the diaphragm as a dome-shaped parachute pulling air into your lungs. The origins are like anchor points holding the parachute's edges, bolted to stable structures. Sternal, xiphoid process, chest's front anchor. Costal, lower ribs, side anchors for chest expansion. Lumbar, L1, L3 vertebrae, back anchors for spine stability. These spots don't move much, grounding the diaphragm's pull. The insertion, the central tendon, is the parachute's center, where all muscle fibers tug when contracting, moving downward to flatten the dome, sucking air in. This setup maximizes lung expansion by pulling from all directions, front, sides, back, to create a strong vacuum, tying directly to breathing efficiency, which protects organs like kidneys and sickle cell by ensuring oxygen flow. Remembering it, origins are the stable base camp, sternum, ribs, spine.
Okay,
Insertion.
tell me from the beginning, and I will do my best to remember to understand.
Diaphragm's origins: sternal, xiphoid process, costal, lower ribs, lumbar, L1, L3 vertebrae.
Dude, this is arbitrary. No, the critical thinking type one. That's what I want to hear.
All right, let's frame diaphragm origins and insertion with critical thinking, making it logical, not arbitrary. The diaphragm, a breathing muscle, needs stable anchors to pull effectively, so its origins, sternal, xiphoid, front, costal, rib 712, sides, lumbar, L1, L3, back, are chosen for their immovable bony connections, ensuring a firm base to maximize lung expansion when it contracts. The insertion, the central tendon, is the moving point where fibers converge, pulling downward like a piston to increase chest volume, drawing air in, directly supporting oxygenation critical for kidney health
And
and
what
sickle
is
cell
this
disease.
insertion central tendon?
Insertion central tendon, where diaphragm muscle fibers attach and pull downward during contraction, flattening the diaphragm to expand lungs for breathing. It's the moving end, unlike fixed origins.
It's the moving end, unlike fixed origins.
Exactly. Central tendon insertion moves downward.
Where is it, this central tendon?
Central tendon, dome-shaped, tough, flat tissue at the diaphragm center, where muscle fibers insert, located below lungs, moving downward during inspiration.
Interesting. Okay. Remind me the vagus and the phrenic. I get confused and we come back. I just wanted to remind me the brachiocephalic trunk, brachiocephalic vein. Remind me vagus and phrenic. I know these are very specific, guys. Sorry, I'm just.
Vagus nerve, cranial nerve X. Vagus nerve, cranial nerve X, diaphragm sensation through thorax. Phrenic nerve, C3, C5, diaphragm contraction. Brachiocephalic trunk, artery to right carotid subclavian. Brachiocephalic vein, drains head arm to superior vena cava. Got it?
No. Can you explain why? Well, you told me the what. Now I want to understand the why.
Vagus nerve senses diaphragm to monitor tension, aiding breathing reflexes. Phrenic nerve, C3C5, activates diaphragm contraction for inspiration, rooted in cervical spine for robust control. Brachiocephalic trunk, supplies head arm efficiently from aorta's right split. Brachiocephalic vein, drains large head arm venous return to heart, due to anatomical proximity.
Excuse me, guys. Sorry that okay, I'm back and I'm concentrated. Tell me one more time, dude. So we have the phrenic and the vagus. I'll tell you what I know. Well, C3, 4, and 5 keeps your diaphragm alive. Has to do with the phrenic, right?
Yes. Phrenic nerve, C3C5, drives diaphragm contraction for breathing. Vagus nerve, cranial X, handles diaphragm sensation, aiding reflex control. Brachiocephalic trunk.
Where did we get the names vagus and phrenic?
Vagus, Latin for wandering, as cranial nerve X travels far through thorax abdomen. Phrenic, Greek phren, diaphragm mind, for C3C5 nerve controlling diaphragm contraction.
I don't get the. Tell me again the etymology.
Vagus, from Latin vagus, wandering, due to cranial nerve X's long path through thorax abdomen. Phrenic, from Greek phren, diaphragm, for C3C5 nerve innervating the diaphragm.
Remind me the branching with the superior vena cava a bit. We have brachiocephalic trunk. We have left common carotid, I think, and we also have subclavian vein.
Superior vena cava receives left, right brachiocephalic veins, not trunk, each merging internal jugular and subclavian veins. Brachiocephalic trunk, artery, branches into right common carotid and right subclavian, not left carotid.
Wait, maybe I'm confused with the aortic arch.
Aortic arch branches. Brachiocephalic trunk, to right common carotid, right subclavian. Left common carotid, left subclavian. Superior vena cava gets left right brachiocephalic veins from internal jugular, subclavian veins, not the trunk. Clear?
One more time. Tell me the superior vena cava. Left and right brachiocephalic, it goes.
Superior vena cava receives left and right brachiocephalic veins, each formed by internal jugular and subclavian veins draining head and arms. Aortic arch, unrelated, branches into brachiocephalic trunk, left common carotid, left subclavian.
Okay. I see. Sorry guys, I'm doing a bit of a questionnaire here about random structures because we're gonna do the last 10 minutes are gonna be slightly more difficult because I'm a bit confused on that. I'm just doing this which is a bit easier. Okay. Now with the lungs, we have the apex and the base obviously. We've got the hilum, we have pulmonary arteries and veins, we've got the bronchus. Is there blood inside the bronchus?
No. Blood isn't inside the bronchus. It's an airway for air to alveoli. Bronchus lies near pulmonary arteries veins at the hilum, where they enter lungs.
Okay. Okay. Let's talk a bit about the openings of the diaphragm. So we have caval hiatus, esophageal hiatus, and aortic hiatus.
Diaphragm openings. Caval hiatus, T8. Inferior vena cava passes to heart. Esophageal hiatus, T10. Esophagus and vagus nerves pass to stomach. Aortic hiatus, T12. Aorto and thoracic duct pass to abdomen.
So caval, esophageal, and aortic.
Yes. Caval hiatus, T8. Inferior vena cava. Esophageal hiatus, T10.
You're
Esophagus.
butchering the. I mean, I say hiatus pretty bad with my stupid accent, but yours is even worse. What is the point of these openings, dude?
My bad on
Hey, dude,
hiatus.
don't laugh. You're unconscious.
All right, chill. These openings like key structures pass through the diaphragm. Caval, vena cava to heart. Esophageal, esophagus vagus to stomach. Aortic, aorta thoracic duct to abdomen, ensuring blood flow, digestion, and
And why do you
circulation.
think it's the vena cava one is the most superior, and then aortic is the most inferior, and esophageal is in the middle?
Caval hiatus, T8, most superior, aligns with vena cava's direct path to heart. Esophageal hiatus, T10, middle, suits esophagus's midline descent. Aortic hiatus, T12, most inferior, follows aorta's posterior course along spine. Anatomical positioning optimizes structural efficiency.
Interesting. Okay. And why does the thoracic duct and azygos vein also pass through the aortic specifically and not one of the other two?
Thoracic duct and azygos vein pass through aortic hiatus, T12, because they run posterior along the spine, aligning with aorta's path. Unlike the vena cava or esophagus, which have separate, more anterior, midline roots.
Okay. I don't get your answer.
Thoracic duct and azygos vein pass through aortic hiatus, T12, as they travel close to the spine, bundled with the aorta, while caval and esophageal hiatus serve distinct, more forward structures, vena cava, esophagus. Clear?
No. I don't get it. I don't get it, bro.
All right. Thoracic duct and azygos vein go through aortic hiatus, T12, because they're tucked behind, near the spine with the aorta. Unlike vena cava or esophagus, which need their own forward holes.
But why were they there in the first place?
Thoracic duct and azygos vein are near the spine due to embryonic development, where lymphatic and venous drainage form posteriorly, aligning with the aorta's path, naturally routing through aortic hiatus, T12, for efficient passage.
Okay. Let's talk a bit about the actions of the diaphragm. So, what does it do?
Diaphragm contracts, flattens, lowering intrapleural pressure to expand lungs for inspiration. Relaxes, recoiling upward to aid passive expiration.
Okay. So we mentioned with the phrenic nerve, C3, 4, and 5, and all of that. I just
Yes,
really don't
phrenic
understand
nerve,
why the motor supply and the sensory is different. What you were saying with the vagus and the phrenic.
Phrenic nerve, C3-C5, provides motor diaphragm contraction and sensory central diaphragm innervation. Vagus nerve, cranial X, only supplies sensory innervation to peripheral diaphragm, reflecting distinct embryonic nerve origins.
One more time. Tell me one more time, please. So it also provides sensory to the pericardium and the parietal pleura and the central region of the diaphragm, but motor to the diaphragm solely. I don't get this.
Phrenic nerve, C3-C5, gives motor innervation, diaphragm contraction, and sensory innervation. Central diaphragm, pericardium, parietal pleura. Vagus nerve provides sensory only to peripheral diaphragm due to separate nerve development.
Yeah, but why? This is not a good answer. Go deeper.
Phrenic nerve, C3-C5, handles motor, diaphragm movement, and sensory, central diaphragm, pericardium, pleura, because it derives from cervical segments, C3-C5, that embryologically form the diaphragm's core, needing full control and feedback. Vagus nerve, from cranial origins, only senses peripheral diaphragm as it passes through, reflecting evolutionary division of labor for precise breathing regulation.
Okay, let's talk a bit about referred pain too. So we have somatic afferent from dermatome C3, C4, C5. We have the phrenic nerve, motor and sensory supply. So the phrenic nerve contains afferent and visceral afferent fibers. We have the visceral afferent fibers carrying sensory information from the diaphragm. Fucking hell, dude. Please just, you know what? I'm giving you full control over this. Explain it to us.
All right, let's break down referred pain from the diaphragm via the phrenic nerve, keeping it clear. The phrenic nerve, C3-C5, provides motor innervation for diaphragm contraction and sensory innervation to the central diaphragm, pericardium, and parabeneal pleura. It contains somatic afferent fibers from C through C5 dermatomes, sensing shoulder neck pain, and visceral afferent fibers sensing diaphragm, pericardium, pleura irritation. Diaphragm irritation, EG4, from inflammation, activates visceral afferents, but the brain misinterprets this as pain in the C3-C5 dermatomes, shoulder neck, causing referred pain because these nerves share spinal cord segments. This can affect breathing mechanics, indirectly impacting kidney oxygenation in sickle cell disease. Want me to focus on referred pain examples or nerve pathways?
It's alright. I'm gonna call it a day. Thank you so much, guys, for listening, and peace.